Hi, my name is Sophia Sturpey. I am a sophomore at Binghamton University, and this semester I completed my research project with Dr. Baim, a trauma surgeon here, Dr. Paramore, a neurosurgeon here, and Bryant Morocchio, who is a general surgery resident. So we looked at introducing the brain injury guidelines at a level 2 rural trauma center. And for a little bit of background information about traumatic brain injuries, they're caused by a forceful bump, blow, or jolt to the head or body, and they can be either penetrating, which is when like an object pierces the skull, or they can be non-penetrating, as in a force to the head shakes the brain very strongly. So there are about 2.5 million emergency room cases per year, with 11% of that total being hospitalized, 30% suffering from a permanent disability, and 2% dying. And traumatic brain injuries can be caused by a variety of different situations, from anything as simple as just being struck by some object to a severe road traffic accident. And when we talk about a traumatic brain injury, yes, we're talking about an injury to the brain, but what actually is really being afflicted here? So in our skull, we have layers called the meninges. These meninge layers, they protect the brain from moving in the skull and they support the central nervous system, the brain and the spinal cord. So we have in the image on the right, the dura, which is in the blue, that's the outer layer, the arachnoid, which is the middle layer, and the pia, which is the bottom layer right against the brain that delivers blood through blood vessels to the brain. And for some types of traumatic brain injuries, these are the meninges. These are where they're getting injured. So in a subdural hematoma, we have an accumulation of blood between the dura, which is the outer meninge layer, and the arachnoid middle layer. And for an epidural hematoma, we have an accumulation of blood between the skull and the outer dura layer. With the subdural hematoma, those are usually more common, but also more deadly. And what these types of injuries can cause is something called a mass effect. So we see all this blood, it leads to the brain being compressed because the skull is a restricted space. So once this brain is compressed, there's nowhere for it to go. This causes an increase in intracranial pressure, and that can lead to this phenomenon, which we call a mass effect. So another type of traumatic brain injury is an intraparenchymal hematoma. The brain parenchyma is the glial cells and the neurons, which are brain cells in brain tissue. So this injury accounts for 10 to 20% of all strokes. And an intraventricular hematoma is bleeding in the brain ventricles, which on this image of a CT scan on the right, the brain ventricles in the center are abnormal. They are not supposed to look like that. And this injury can be very severe with an expected mortality between 50% to 80%. And another traumatic brain injury is something called a subarachnoid hemorrhage. And patients describe this injury as being the worst headache they've ever experienced in their life. So basically, it's when a weakened blood vessel, it could be due to an aneurysm or some type of trauma to the head, bursts in the brain, and it's bleeding between the brain and the subarachnoid space. This CT scan on the right is an image of the light gray in the subarachnoid space, and that light gray is abnormal. It's due to the presence of blood. So when we talk about traumatic brain injuries, how do we really assess these types of injuries and, see how they happen? So we look at something called the Glasgow Coma Scale, which tests a person's impaired conscious level. So we look at the people's eye opening, their verbal response, and their motor response. And a mild score, meaning a mild impaired consciousness level, is between 13 and 15. A moderate level is 9 to 12, and a severe is 3 to 8. So we add up the scores from each column. So if their eyes open to sound, that's a 3. If their verbal response is only in words, that's also a 3. And if they can obey commands, such as they can squeeze your hand when you tell them to, that's a 6. So that's a 12. So that's a moderate Glasgow scale coma score, meaning that there's a moderate injury impaired consciousness level. And whether you have a mild traumatic brain injury or a serious traumatic brain injury, they can affect all facets of your daily life. We're talking about lack of focus, difficulty with reading, blurred vision, problems with memory, difficulty walking, difficulty swallowing, facets of all of your life. And it can affect anything from a short time to your whole entire life that these effects can last for. In addition, traumatic brain injuries, they can cause mood disorders, epilepsy, and dementia. It's a very serious thing. And what I think is most interesting is that this graph on the right, showing 5-year outcomes of persons with moderate to severe traumatic brain injuries. We see that about a quarter for each category. A quarter die about, a quarter become worse, a quarter approximately stay the same, and a quarter improve. So, as providers, how can we quantify which people will improve and which people will become worse? Meaning, how can we allocate resources best so that the people who are at risk of becoming worse, who are going maybe possibly to die, can get the best resources and the most resources available, while the people who are going to improve and stay the same with minimal intervention can also get that care that they need, but not being taking away that bed, that emergency room bed, from the people who are going to become worse. So the problem I'm speaking to is emergency room overcrowding. So essentially, in the United States, we have a problem with our emergency rooms where patients are waiting hours, even days, to get an emergency room bed. I heard from a provider at Robert Packer Hospital that recently our trauma room had an diversion, meaning that patients there was not safe enough to accommodate more patients, so we were not able to safely accommodate more patients. So these are problems that are affecting not just Robert Packer Hospital, but hospitals all around the country. And so, as providers, what can we do to alleviate this concern? So, our research project is looking at something called the BIG guidelines, the brain injury guidelines. And these guidelines were developed by acute care surgeons and also neurosurgeons, trauma surgeons to basically categorize people with traumatic brain injuries into certain categories. So, big one is a person with a minor traumatic brain injury. Big two is a person with a moderate traumatic brain injury. And big three is a person with a severe traumatic brain injury. And these people are quantified into these categories based on their symptoms and the appropriate treatment necessary. Now, these guidelines, they've been validated for level 1 and level 3 trauma centers, but they have not been validated as far as we know for level 2 trauma centers. So this is Martin et al.'s analysis of the updated brain injury guidelines for a level 3 trauma center. So they have a lot of variables that they're looking at on the left. They have the Glasgow Coma score, they have intoxication, they have subdural hematoma, that's the SDH. And based on those variables, they have a therapeutic plan on the bottom. So for a big one, for example, they require hospitalization observation for 6 hours, but no transfer to higher level of care. However, if you're in the big three category, you need hospitalization or repeat head CT, a neurosurgery consult, and transfer to higher level of care. So our experiment analyzes these big criteria, and we're hoping to validate the big criteria for a level 2 trauma center, which is the level of Robert Packer Hospital's trauma center. So we're hoping to stratify admitted patients into a big category, assess the necessary level of care for the patient based upon the assigned big category, and determine patient outcomes. So we conducted a retrospective medical records review. We used Epic and we also used Microsoft Excel, and we looked at trauma patients admitted between January 1st, 2018 and December 31st, 2022. We looked at a total of 458 patients. 138 were in the big 1 category, 54 were in the big 2 category, and 266 were in the big 3 category. And we looked at a variety of different data points or variables. We looked at the GCS score, length of stay in the hospital, discharge destination, results of CT scans. We also looked at whether they were on antiplatelets or anticoagulants, if they were transferred here, what location were they transferred here to. And for our results, we found that the traumatic brain injury type among big 1 and big 2 patients was primarily a subdural hematoma, an intraparenchymal hematoma, and a subarachnoid hemorrhage. We also found that both people in the big 1 and big 2 categories had a repeat CT and had progression, meaning there was a change in that repeat CT, but there was no clinically significant progression. We found that an average GCS score for big 1 and big 2 patients was about 14, 15, while big 3 patients was about 12. And this makes sense again because the big 3 patients tend to have more severe traumatic brain injuries, and that would make sense that they have a lower GCS score. The average age for big 1 and big 3 patients was relatively similar, with big 1 patients having an average age of 63 and big 3 patients having the average age of 64. And the average length of stay among all the categories for big 3 The length of stay on average was about 5 days in the hospital, and the average length of stay in the ICU was about 2 days. And again, this makes sense being that the big threes have the most severe traumatic brain injuries. It makes sense they would need the longer length of stay. And also, the big three patients, they had an average length of stay of 3 days before being discharged home. And in addition, the big threes had an average length of stay of about 9 days before they were discharged to rehab. So this graph is specifically about the discharge location. And finally, I think this is one of the most important pieces of data we have here today. The big three patients had a number of deaths of 33 mortalities. The big two patients had 0 mortalities, and there was 1 mortality in the big one group. However, that 1 mortality in the big one group we found was not due to a traumatic brain injury. It was due to another organ system failing in the body and the family's decision to go into comfort care for that patient. So, being that the one mortality was not attributed to head injury, we can say that this study likely validates the application of the big criteria to a level 2 trauma center. And this is simply because that the big three patients tended to have the longer length of stays, they had more mortalities, and they also had a lower, more severe GCS score. And this means that our criteria is working because the big threes, the most severe traumatic brain injuries, are having the longer length of stay and all these outcomes that are associated with more severe traumatic brain injuries. Particularly being that the big one and the big two categories had no mortalities due to their traumatic brain injury, we can say that this criteria is working in sorting very severe patients to a big three category and the less traumatic, less severe injuries to the big one categories. So ultimately, we are saying that this study likely validates the application of the big criteria to a level 2 trauma center. And especially, we are posing the question that if our data set and our criteria is working, why do those patients in that big one category, why were they transferred from another facility to Robert Packer Hospital in the first place? If this big one criteria is working, perhaps they should stay at another area with maybe perhaps less resources than Robert Packer Hospital. Stay there, be under observation for 6 hours, and then assess after that, instead of coming to Robert Packer Hospital and occupying a bed that could be used by a big three patient or a patient with a more severe injury. So ultimately, we are hoping to improve the resource utilization of Robert Packer Hospital's Level 2 Trauma Center. Some limitations of our study: we had 458 total patients we were analyzing, but that in no way represents the millions of people who use emergency rooms in the US each year. In addition, we had some time constraints. I think if we perhaps had a year or more time, we could have had a bigger sample size or maybe used a longer time range in our study. We are also the first study to be looking, as far as we know, to be looking at a level 2 trauma center. So we are, in a sense, paving the way in that regards. And because we are a retrospective study, the data was collected in the past. And so they did not know that we were going to be conducting this study in the future. So sometimes there can be recall biases, there can be confounding factors. For example, our one death in the big one category due to an organ system failure that wasn't a traumatic brain injury, that can kind of confound our results. And for some future research, we could analyze a longer time range, a larger sample size. We could incorporate a survey component to analyze present day data. But I think the most important thing is that we extrapolate these findings to other rural hospitals and analyze the big criteria in other hospital emergency rooms. Ultimately, I think these criteria, they can save time and money for both the patient in terms of not having to wait in ER waiting rooms, not having to get extra CT scans that can have an extreme financial burden on patients. And it also saves time and money for the physicians in terms of that they do not have to go to all these neurosurgical consults. So I think ultimately these big guidelines can have a very, very significant impact on our US healthcare system. So I would like to acknowledge many people and thank them. So I'd like to thank Dr. Robert Baim. He's a trauma surgeon here, for all of his amazing support and guidance and for being with me every step of the way for this research project. In addition, I'd like to thank Dr. Paramore and Dr. Marocchio for answering any questions about eye research, and Vicky Hickey for just all of her guidance and all of her knowledge about this area. Kyle Williams for coordinating all of these amazing internship experiences. I'm sure it was very difficult, and all the Guthrie providers and staff across the system for being so welcoming and so supportive as I shadow in all of their specialties and being so passionate about what they're doing. And in addition, I have to thank Dr. Stephen Ortiz, the Executive Director of the Binghamton University Scholars Program, and Catherine Bowman, the Senior Assistant Director of the Binghamton University Scholars Program, for all of their support and assistance. They've been with me every step of the way. And here are my references. Thank you very much for listening, and thank you.